Today, I'm going to convince you that all of you should be using point-of-care ultrasound, or POCUS, at the bedside for many of your patient evaluations. Some of you have already experienced using ultrasound as part of clinical practice. Others have learned enough about clinical ultrasound to be interested in its clinical use. And maybe some of you are wondering whether learning yet another task for clinical medicine is really worthwhile. I'm here to tell you that this technological development has revolutionized clinical medicine, and that ultimately learning to use clinical ultrasound is a plus for delivering better patient care. Understanding how ultrasound is used in daily clinical practice is not intuitive. I'm not going to spend much time talking about the how to do ultrasound at the bedside, but rather we'll review what clinical ultrasound currently is, and also we'll review examples of why this technology is great for clinical care, why you developing the skills at clinical ultrasound is so important. There are really two aspects of point-of-care ultrasound. First is how the technology is rapidly evolving to make relatively powerful ultrasounds affordable and available to all clinicians. Second is how diverse specialties are now incorporating ultrasound into clinical practice and training. Here's an early ultrasound system from the 60s. It was large, not very user-friendly, and did not have great image resolution. As data processing advanced, these early systems have evolved into more powerful and portable ones. There also has been good research supporting that ultrasound is useful as a diagnostic tool for some diverse presentations and pathology. These big systems remained relatively expensive, and therefore ultrasound remained a radiology specialty. However, in the early 90s, systems were marketed which were relatively small, powerful, and, most importantly, affordable. Some specialties, including emergency medicine, began the paradigm of providers using these systems at the bedside to enhance patient care and bedside diagnostics. I was fortunate enough to have been starting my EM residency when the first system showed up on the floor, and we were all able to try and figure out how to use it in clinical practice. Over the past 5 years, there has been a dramatic change in technology with the advent of smaller and even more affordable systems. This system is the Lumify. It's really 3 different transducers which can plug into a PC tablet and has great image resolution. The medical school owns 40 of these, and medical students are able to sign them out to start using POCUS in a clinical setting. This system is the Butterfly. It's solid state and plugs into any iPhone. This one transducer can do diverse image acquisition, normally requiring multiple different transducers. While most transistors typically cost $5,000 to $10,000, this device is projected to have a price point of about $500. In other words, anyone who can afford a cell phone will be able to buy an ultrasound system. This is a game changer, especially in resource-limited settings. Now, one result of systems becoming cheaper and smaller is that clinicians from diverse specialties now have access to ultrasound and want to use POCUS for their clinical practice. There is legitimate concern about how to train and QA providers to safely use POCUS at the bedside. In the reality of these new cheap systems proliferating, regulating use will be a daunting task, especially as we don't routinely QA clinical skills or stethoscope use. This is one protocol being developed here at UVM in an effort to establish standards and guidelines for credentialing use. Want to know what's really driving all of this change in clinical medicine? It's you. You are part of a tidal wave. This was the first ultrasound training session offered to medical students 2 years ago at UVM. As you know, UVM now has a 4-year integrated ultrasound curriculum, with medical students learning about clinical ultrasound at the beginning of their first year. As the curriculum is further developed, the goal is for students to learn to use clinical ultrasound as a routine part of clinical assessment and patient care. Ultimately, the goal is that every medical student graduating from UVM will think it's the norm to use an ultrasound at the bedside to supplement their clinical exam. They will expect that faculty and mentors are facile at this technology. that their clinical residency program includes training in ultrasound as part of the curriculum. Now, I trained in emergency medicine before we had a formal training program. In the interim, ultrasound has become part of EM residency core curriculum since 2004. For emergency medicine, the current practice standard is that ultrasound is routinely used as part of clinical practice. Most other clinical specialties are just starting to incorporate clinical ultrasound into their training and practice. Many of your current faculty and mentors did not have this technology available as part of their medical school training or residency training. The challenge is to convince them and you that the effort in learning ultrasound is ultimately worth it. For me, I've had cases over the years, and now have a case almost every clinical shift, which reinforces why ultrasound is so important. Here's a case from early in my career. Imagine that you were in my shoes, moonlighting overnight in a rural community hospital. Everything is quiet when an EMS call comes over the radio, a call that everyone dreads to hear. They're bringing in a 2-year-old in cardiac arrest with a 25-minute transport time. How many of you have been involved in a pediatric cardiac arrest? These cases are awful. Most patients in arrest don't survive, and having to manage a pediatric cardiac arrest is especially devastating. EMTs had already managed the airway, administered drugs, had CPR in progress, and were still 20 minutes out. We were all prepped for the worst. EMS arrived with CPR still ongoing. We did everything right. Continued CPR, placed the definitive airway, got more IV access, gave additional drugs, but the child remained apneic with no palpable pulse. So, I started having the conversation in the room about stopping CPR, about shutting off the vent. I also had to prepare to talk to this child's parents and tell them that their toddler had died. There was an ultrasound in the recess room, and before calling the code, I grabbed the machine, put a transducer on the chest, and saw this. You don't have to be an expert in ultrasound to interpret this image. This is a beating heart, and it's actually beating really well with good cardiac output. Even after getting this image, we still couldn't palpate a pulse, but we were able to stop CPR while continuing ventilation and resuscitation. Most importantly, instead of shutting off the vent on this apneic patient in what would have been a terminal decision, we began arranging transport to a tertiary care children's hospital. Instead of telling mom and dad about their dead toddler, I was able to go out and tell them that their child was very sick, but alive. So how come we couldn't palpate a pulse? This is not what I was taught. As it turns out, there's a lot of literature which suggests that clinical exam findings are often not as sensitive as we think they are. This was a cool study by Tibbles in 2008, which evaluated the ability of doctors and nurses to assess if a pulse was present in pediatric patients in the ICU on ECMO. Think about this. This is the ideal environment to assess a pulse. It's quiet. There's none of the usual noise or stress of a real resuscitation. But even under ideal conditions, providers are only correct about 3/4 of the time. That means 1/4 of the time they would have made a wrong decision in a resuscitation. About 14% of the time, they would have withheld CPR when needed. 1/3 of the time, they would have been performing CPR when not needed, but also likely stopping ventilation when a pulse was not palpable, like the case I had above. Think about how many codes get run without ultrasound. It's pretty sobering. Here's another case which changed my practice. A 38-year-old woman came to the ED with new severe abdominal pain. She was not in distress, had no history of previous abdominal pain, but had mild hypotension on arrival. And she was too anxious to lie down. Note to self, impending death is usually anxiety-evoking. Something was wrong. So I literally paced with her in the room with a transducer on her belly and saw this. You don't need to know much about ultrasound to see something's going on. In ultrasound world, fluid is black. Do you see fluid in her abdomen? Yes, there's quite a bit. That's not normal, and in a young woman with sudden belly pain, that's probably blood. And if you look closely at this image, there is a donut-shaped structure. That's her ectopic pregnancy. She was in the operating room before we even had a beta HCG and had 3 liters of blood in her belly. Finally, the dad of one of the EMTs from across the lake was hanging out with the crew for lunch when he suddenly developed chest pain and looked like heck. The EMTs immediately performed a quick EKG, which wasn't diagnostic, and then they made a pretty tough decision. They decided to bypass their local critical access hospital and drive over an hour to UVM. And that turned out to be the right decision, because if a patient with sudden chest or abdominal pain, who generally looks horrible, has a normal EKG, they're probably having a vascular catastrophe. I was ready with an ultrasound transducer on his arrival and got this image even before he was transferred from the EMS gurney. He has a huge aortic aneurysm with clot in the lumen, and when I added color, he has obvious retroperitoneal extravasation. Within 15 minutes of arrival, he was getting uncross-matched blood and was transferred to the operating room. Now, he might have survived if he was managed with usual testing, but mortality increases significantly with delay in care. And think about how many at-risk patients present in the outpatient setting with abdominal pain. Now, all of these cases had a great outcome. Ultrasound at the bedside made a real difference. But here's one more case that may be even more convincing. A 68-year-old woman presented to our emergency department with atraumatic left hip pain. She had a normal exam with no reproducible tenderness in her hip or abdomen. What's the problem? My colleague taking care of her did usual care. Got normal labs, a normal UA, and a hip x-ray with no evidence of pathology. The patient had improved pain after receiving Tylenol. She was in our ED for over 5 hours, waiting as an MRI and outpatient support were set up until she codes and dies from a ruptured AAA. Now, my colleague was skilled at aortic sonography, and there was an ultrasound system literally 20 feet from the patient's bed. It would have been easy to ask whether someone with atypical atraumatic pain had an aneurysm. Just had to look. There's an important take-home from all these cases. History and clinical exam skill alone was not enough to make the correct diagnosis for any of these patients. One other test was crucial to have at the bedside to make a rapid diagnosis: point-of-care ultrasound. Think about your vision of medicine. When you decided to go to med school, I bet most of you had an image of being a caregiver at the bedside, of interacting with patient and family, making a bedside diagnosis, and successfully treating your patient. I bet none of you envisioned struggling with an electronic medical record or feeling as if you were spending more time in front of a screen instead of with your patients. But one truth about medicine for all of us is that there are limitations in our ability to make an accurate diagnosis by history and clinical exam alone. That's okay for most low-risk patients, but as in the case above of the woman with hip pain, low risk is not no risk. All of us have had or will have some tough cases where we will ask, what could I have done differently? Could I have done something earlier? One way for us to get past some of our clinical limitations is to order additional testing. Testing clearly has revolutionized medicine, made it possible to make a lot of crucial diagnoses, but there are some real downsides and risks to testing. First, we now test way more than we really have to. Think about how many patients you have seen that you don't order a test on. Many tests are negative. That includes use of advanced imaging like CT or MRI. If you present to the UVM ED with abdominal pain, there's a 50% chance that an abdominal CT will be ordered. And of those CTs, only 1 to 2% will be positive. And sometimes, positive means an incidental finding that has no bearing on why the patient had the test ordered in the first place. This now leads to more testing or over-testing. Another downside of testing, especially in the outpatient setting, is that it makes the practice of medicine really impersonal and often really frustrating for both patient and provider. Once a test is ordered, the patient often has to go somewhere else for the test, and the result may not even be available at the time of the initial visit. So at least the test ordered should have some specific value. Performing an ultrasound at the bedside is certainly another test, but it is done at the bedside and gives an immediate answer. What is clinical ultrasound, and why is it such a game changer? It's another tool to use at the bedside to get more information about your patient than by clinical exam alone. With clinical ultrasound, a provider asks a focused question at the bedside. Does my patient have gallstones? Do they have hydronephrosis? Do they have a pneumonia? And with clinical ultrasound, the provider can get a specific yes or no answer at the bedside with their patient. Sometimes the answer will change management. Sometimes it'll not be sufficient and another more comprehensive study might be needed. but even the negative ultrasound image helps steer clinical decision-making. For those of us who use ultrasound routinely, this ability to get more clinical information at the bedside is really amazing. Getting good at using POCUS in the clinical setting takes practice. When and how to acquire and interpret an image like this to make a clinical decision seems far from intuitive. But think about the first time you went into a room to do an H&P, or the first time you did a procedure. I bet that those initial times were a little overwhelming, and now that you've had practice, they're a little more routine. Learning ultrasound applications is the same paradigm. It's pattern recognition. Here's a test. I'm going to flip through some slides and see if you can recognize the complex images. Ready? Everyone can recognize this. How about this one? These are similar, but clearly different. How about this image? No problem here. Or this one? Remember when you first tried to read one of these? Some black squiggly lines on red check paper? For most of you, this tracing now has a lot more meaning. So this image may be confusing at first, but rapidly starts to make sense. This has been generated by a curved ultrasound transducer placed on the patient. As sound waves are emitted by the transducer and then bounce back, the system's data processor generates an image. Now the image is based on how sound waves reflect from the structure. Dark areas are not good reflectors of sound waves and are called hypoechoic. These areas generally have more fluid present. Really white areas are more reflective of sound waves and are called hyperechoic. This is tissue that is generally more solid. After a while, you will recognize tissue in shapes like this liver or this kidney. Not really that difficult, and certainly more information than pushing or listening on the surface. Now, I work in a setting where testing is easy, maybe even too easy. I can get a comprehensive ultrasound 24/7. And even in this setting, I do a lot of my own bedside ultrasounds. Why? In addition to being a great diagnostic tool, use of ultrasound has all of these advantages. I get to spend more time with my patient. I'm often faster at diagnostic testing, at dispositioning my patient. And I make the diagnosis with my patient. They get to look at the screen, and although they probably have no idea what they're looking at, the discussion in real time has a lot of value. For me personally, the ability to stay with my patient and make a diagnosis is great. Now, this is a family medicine clerkship, and many of you will work in an office or primary care setting. It's really in the clinic setting in which the use of POCUS is even more profound. Instead of referring your patient elsewhere for a test or having them come back to review results, you do one specific additional test in real time with them. And think about the common patient complaints that you manage daily. Patients come in with chest pain, respiratory disease, or abdominal pain. They present with rashes or swelling. And they present with traumatic injury, bumps, bruises, or foreign bodies. Clinical ultrasound is great for all of these presentations. Let's check out a few cases. A 52-year-old came by after having an atypical episode of chest pain while he was at the gym. By the time he saw me, and could have just as easily saw you in an office, he had no pain, normal vital signs, a normal EKG, and had a normal troponin. By any chest pain risk stratification tool, he would have been discharged for an outpatient stress test as follow-up. Except something wasn't right. It's easy to throw a transducer on his chest. This is an echo of his heart. Pay attention to this tube, the ascending aorta. Vessels should only have 2 walls. This has 3, and this is his thoracic dissection flap in an asymptomatic patient with normal vital signs. Or how about the 7-year-old who comes in with fatigue and weakness 2 weeks after she had an upper respiratory infection? How many kids present like this? Her exam is normal except for a fast heart rate, and it would be easy to diagnose her with another viral infection. But here's her heart. Remember how in ultrasound world, fluid is black? If you look at the outside of the heart, there's a small pleural effusion. So at least this girl has pericarditis. But something else in this image doesn't look right. So check out a different view. In this image, her ventricle isn't beating correctly. She has a perimyocarditis and needs transfer to a children's hospital in Boston for a possible heart transplant. We see tons of patients like Mr. Smith. He actively smokes with COPD, and he also has CAD, CHF, diabetes, and he's often non-compliant with his medications. And he comes in all the time with respiratory complaints. Which one of his chronic problems is the cause? Well, it could be anything. We also see lots of patients with increased congestion and work of breathing, and often with a worried parent. And the question usually being asked is if they have a pneumonia or not. So we do an H&P to figure it out, right? We percuss, we auscultate, and we get all sorts of sounds and information at the bedside. And we use this information to make a diagnosis. The problem is, it's not that easy to translate general sounds and history to a specific correct diagnosis. There's actually a lot of literature out there which suggests that we're not as good at clinical diagnosis as we think we are. This paper asked EM providers to write down the diagnosis on patients presenting with respiratory complaints after performing a history and physical alone. Then the patients proceeded with usual care. None of the providers were that accurate. This is much harder than we think. History alone was correct only about 40% of the time. That's worse than guessing. Adding auscultation with our trusty wheeze detector didn't improve diagnostic accuracy at all. Here's another cool study in which patients with known pneumonias were randomized with patients who didn't have the disease. Providers were asked to assess by H&P alone who had the pneumonia. And similar to the previous study, the ability to make the correct diagnosis was pretty poor. Well, that's okay because you've learned that if you're really concerned about diagnosing respiratory disease in a patient, you can order an X-ray. The original definition of pneumonia was based on a chest X-ray finding. If a patient's X-ray showed an infiltrate, the patient had a pneumonia and was treated with antibiotics. If the X-ray was normal, the patient had bronchitis and didn't need antibiotics. CHF was diagnosed with a chest film that had curly bee lines, peribronchial cuffing, etc. But with the advent of a more accurate test, the CT scan, the sensitivity of the chest X-ray turns out to be not that good. Here's an X-ray I ordered last week on a patient I thought had CHF. You should be familiar with this type of interpretation. Possible pneumonitis or pulmonary edema, but then again, maybe a pneumonia. The X-ray is just not as accurate as we like to think. For a long time, chest X-ray was the best imaging modality we had. We now have CT scanners which are much more accurate. There are studies which compare the accuracy of chest X-ray to CT. This was a well-done study which documented a chest X-ray miss rate of 31%. In other words, a third of the time you order the test to dictate how to treat your patient, it's a false negative. If you look at all the studies on the sensitivity of chest X-ray in diagnosing pneumonia, it turns out that X-ray is at best wrong a quarter of the time, and that was a poor study. Most of the data suggests that the chest X-ray misses about a third of CT-diagnosed pneumonias. Again, that means 1/3 of the time you're ordering a chest X-ray to help supplement your clinical exam, it won't give you the correct answer. Now, this is a talk about ultrasound, and guess what? Ultrasound can be used at the bedside to assess for pulmonary pathology. And there have been studies which also compared POCUS to CT for diagnostic accuracy. Even the worst sensitivity for ultrasound is still better than the best test for chest X-ray. Here's the most recent meta-analysis evaluating the use of POCUS to diagnose pneumonia. If a positive likelihood ratio is greater than 10, the test is great. The positive likelihood ratio in this study is 15. If your likelihood ratio is less than 0.1, the test is great as a negative predictor. The negative likelihood ratio in this study is 0.9. It's really rare to have these kinds of numbers in a study. How about ultrasound for CHF? Remember this X-ray? If you look at the literature on using X-ray to diagnose CHF, it's not really a good test. It only picks up the disease about 50% of the time. Compare that with clinical ultrasound. This is the ultrasound I did on the same patient with an equivocal X-ray. The image has findings consistent with CHF and a pleural effusion. No question. This is the most recent meta-analysis evaluating the sensitivity of POCUS in diagnosing CHF. Just like the one for pneumonia, the likelihood ratio is amazing. A positive likelihood ratio of over 12 and a negative likelihood ratio 0.06. Point-of-care ultrasound for CHF is a great test. Finally, here's a study which compared chest X-ray and ultrasound to CT scan findings in critically ill patients. Patients you'd expect to have some obvious radiographic disease. Once again, X-ray doesn't perform well. It picked up pneumonias about 2/3 of the time, but otherwise was poor at diagnosing other pulmonary pathology. Ultrasound, on the other hand, was really good. Now, nothing is 100% sensitive, but the point is that bedside thoracic ultrasound is a much better test than chest x-ray or clinical exam alone. Then there are patients who show up with abdominal pain. You've seen Mrs. Jones. She's 45 years old and shows up with right upper quadrant pain after going out for her husband for beers and a burger. She has no history of biliary disease, but her story and exam are perfect for acute biliary colic. Without a bedside ultrasound, you could order lab tests and or refer her for a biliary study. But with POCUS, you could just look. The study might be normal, or you might see something like this: a big boulder stuck in the neck of her gallbladder. This has been there for a long time, but by dumb luck is now symptomatic. And check this out. After giving her some fentanyl and keeping her on her left side, this happens. Her gallstone has moved out of the gallbladder neck, her pain goes away, and she can be discharged without needing any other lab tests or urgent workup. Another reason it's nice to be able to look at the bedside is because sometimes the cause of abdominal pain may be different than you thought. This man had right upper quadrant pain, but instead of his gallbladder being the problem, he had sonographic findings of obstructive nephrolithiasis. Or maybe his kidneys would look normal and you would see that his real pain was from a AAA. Or a quick look in his abdomen would show a bowel obstruction and ascites. Or maybe your patient is an 8-year-old who has belly pain and has ultrasound findings of acute appendicitis. Being able to place a transducer on somebody's abdomen is often immediately diagnostic and helps steer clinical management. How many of you have seen a patient presenting with unilateral leg redness and swelling? Now, this is most likely a cellulitis, and you could just treat this empirically with antibiotics. In the differential is a possibility that this is a DVT, and it's now the norm to risk stratify to rule out DVT as a much more serious cause of this presentation. We have patients referred to the ED for this very question daily. There is good literature supporting the use of point-of-care ultrasound in low-risk patients with possible DVT. It's a test you could do at the bedside. For another patient with cellulitis, you might be concerned about the level of pain and swelling that seems inappropriate. And see this. This is gas from necrotizing fasciitis. And this patient needs emergent IV antibiotics and surgery. We see tons of patients who come in with all sorts of traumatic injury. I saw this 3-year-old who presented 3 times to his PCP with a possible wooden sliver in the web space of his left great toe. At each visit, the provider had used local lidocaine to numb up the skin and done a limited exploration without finding the foreign body. Injections in the foot are really painful. He wasn't really happy to see me for a 4th visit, but with ultrasound, I could do 2 things. First, I could clearly document that a foreign body was present, and I can also localize exactly where it was on the foot. Ultrasound is great for this. I could also use ultrasound for this, regional anesthesia. Instead of stabbing his foot again with a needle, I could briefly use a small insulin syringe away from the sensitive area of his foot to numb skin, reassuring the boy that he wouldn't feel any other pain. And a little while later, I was able to place a posterior tibial nerve block to make the whole plantar surface of his foot insensate. Here's an ultrasound of the posterior tibial artery and the posterior tibial nerve, and you can see me placing anesthetic right next to the nerve. Then, while this boy was lying on his belly watching SpongeBob on an iPad, we were able to get this sliver out. And he was really mad when we were done. But he wasn't mad about the pain we caused. He was mad that we were done before he'd finished the episode of SpongeBob. So this was a brief overview of how ultrasound can be used in the clinical setting. It's a game changer. It's an incredibly powerful technology to use at the bedside. Hopefully, all of you are ready to learn clinical ultrasound and to use this technology as clinicians. The hard part, really, is starting. As I talked about earlier, learning any new skill is challenging. There are really 2 important aspects to learn POCUS. The first is making sure you have the educational support to develop your confidence and competency to make independent decisions based on your own imaging. There has to be administrative buy-in and support. Whether you are in medical school, training in a specialty as a resident, or even practicing as a clinician, It's really important to be in a system which has ultrasound champions. These are mentors or colleagues who are already using the technology and are available to help teach. If you are somewhere where a POCUS program is not really developed, this champion might have to be you. Because ultimately, learning to use this technology is on you. You need to have the right mindset for learning. POCUS is not immediately intuitive, and mastering it takes work, takes commitment. You have to remind yourself that as a result of your commitment, you'll be a better practitioner. And I can tell you, in my experience with ultrasound education, that it sometimes takes multiple sessions for one application to get it right, to develop the muscle memory about image acquisition and image interpretation. But with the right mindset, one application will begin to make sense and you'll be able to use it clinically. Then, learning others becomes less overwhelming. Initially, you won't be confident in making a decision without a confirmatory study. But over time, you'll eventually realize that you are accurately diagnosing all sorts of pathology, pneumonias, CHF, kidney stones, gallbladders, right at the bedside. Then, in addition to being an outstanding clinician with great patient assessment skills, you'll be able to use ultrasound at the bedside when appropriate to get a little more accurate information about your patient. Hopefully, you're now ready to become a clinical ultrasound Jedi Master. Now let's be clear, every patient does not need an ultrasound. But for certain patients, ultrasound is a great adjunct that can really make a difference in patient care. As I've talked about, while POCUS may seem relatively new for some specialties and in medical school, this is not a fad. This is a clinical application of technology that's been used for a while. There's a lot of really good literature which supports that medical providers like yourselves can rapidly learn to use ultrasound effectively at the bedside to benefit patient care. Like any aspect of medical care, this takes some humility. The technology really works if you are focused on how you use it, if you ask a simple question and understand the limitations of the answer. You may not get sonographic information that makes a difference. You might have to do something else to get more information about a specific patient. Learning ultrasound takes work and practice. If you're going to order a comprehensive study on a patient, throw on the transducer yourself and see how good you are. Eventually, you'll get to the point where you don't need to order another test. It's a great accomplishment, and you can get there. The bottom line is that we're all trying to take really good care of our patients. You can continue practice as usual, or you can learn to have a little more skill at the bedside to really make a difference in patient outcomes. Here are some FOAMed resources. There are also some great iBooks either through ultrasoundpodcast.com or through ACEP, the American College of Emergency Physicians. If you have any questions or want more information about point-of-care ultrasound, please contact me at the email address below.